Yes.
Yes, ma'am. I have started the session.
Okay. Sir, you
Yeah,
start,
you
then
can
I
start.
will
Yeah,
introduce
okay.
madam. Yeah.
Sure. Yeah, good morning, everyone, and welcome to the next session of our Indian Academy of Neurology Cognitive Subsection. We have one of the choicest speakers that we have in cognitive neurology in India, one of the leading exponents of frontotemporal dementia, besides all the other dementias, Dr. Ratnavali. Dr. Suman will be introducing Dr. Ratnavali to you. She'll be talking on FTD. And so, Dr. Suman, please.
Thank you, Dr. Amitabha, and it gives me an immense pleasure to introduce Dr. Ratnavali. Her current affiliation are she is consultant neurologist at Manipur Hospital and Anna Swami Muralidhar Hospital at Bangalore at Mysore, and her research interests basically are on prevention of dementia, frontotemporal dementia, primary progressive aphasia in bilinguals. She also works on cognitive reserve and dementia and cognitive biomarkers in dementia in diagnosis in LMIC. And she has recently received the Global Advocacy Leadership Program Award from American Academy of Neurology. And Madam has multiple international and national research paper on frontotemporal dementia in specific. She has also co-founded the LAMC work group for diversity in Alzheimer's Association, and she has been an inspiration to many of the cognitive neurologists in India, including me. So welcome, madam, and she will be speaking on frontotemporal dementia. Over to ma'am.
Thank you very much, Suman and Amitabh and Indian Academy of Neurology, Cognitive Neurology Subsection. Thanks for asking me to talk on one of my favorite topics. I'll just share my screen. It's not allowing me to share now.
Digital team, please help her.
Just yeah, it's visible now. Just
Can you
click on
see
it.
my slides?
I think we will be able to see it. It's sharing.
Yes.
Yes, ma'am. We are able to see. You can go ahead.
And the full screen?
Yeah.
Yes, yes.
Yeah,
Yes,
okay.
please.
Yeah, thank you. So today I'm going to talk about frontotemporal dementia. Hope it doesn't get stuck. So here you can see this is patients presenting with multiple cognitive, behavioral, and motor problems. And so this demonstrates the heterogeneity of the frontotemporal dementia. So patients can present with a variety of symptoms, and it can be fascinating, but also challenging to diagnose FTD in the clinic. So what is frontotemporal dementia? So it's also referred to as frontotemporal lobar degeneration. That is the term FTLD we use when we are talking mainly in terms of neuropathology. So for the clinicians, it's a term FTD is reasonable. So these are heterogeneous group of neurodegenerative disorders which are characterized by frontal and temporal lobe atrophy. So they have three clinical subtypes: the behavioral variant frontotemporal dementia, the semantic variant primary progressive aphasia, the non-fluent primary progressive aphasia, but now are extended to the motor subtypes of motor neuron disease, progressive supranuclear palsy, corticobasal syndrome, as well as the right temporal variant of frontotemporal dementia. So they have distinct patterns of atrophy, which I'll be discussing, and different kinds of protein which are deposited, which could be tau or TDP43 or FUS. So pathologically, they are characterized by neuronal and synaptic loss, gliosis, and atrophy. So clinical presentations and pathological substrates are highly variable. The most important point is that 40% have family history and 20%, sometimes people say up to 25% of patients can have an autosomal dominant mutation. So it's very important that this be considered and detailed family history taken when you encounter a person with FTD. So as I mentioned, they have neuronal and synaptic loss. They have neuronal and glial inclusions depending on the subtype. And they're also characterized by atrophy of the von economo and fork cells, which are mainly seen in anterior cingulate and frontoinsular cortex. And these are associated with very social mammals like elephants, whales, and humans. So they're very characteristic kind of cells, and these are lost in patients with FTD. So 45% of the patients can have tau as an aggregate, and 50% can have TDP, and a very small proportion of patients can have other protein which can be aggregated, and usually these are misfolded. And you can see different kinds of distinguishing features like the PIC bodies in Pick's disease and so on. And the FTLD TDP is characterized by different kinds of, whether it's neuropil threads or the inclusions. It's divided into type A, B, and C. For instance, type C is seen with semantic dementia. So each FTLD neuropathology can be associated with more than one clinical syndrome, and each clinical syndrome may be associated with different FTLD subtypes in different individuals. But there is a reliable association between specific genetic mutations and the underlying pathology. But in sporadic disease, this association can be variable. So I'm not able to play the slide, I think, properly. Can I reshare it because it's showing the whole thing?
Yes, ma'am. You can reshare it again.
No, it's not letting me share again. I do not understand. I'm sorry.
Ashmita, are you able to share, ma'am?
I'm able to share, but it doesn't show me the kind of what I see always with a Zoom presentation. We have done this multiple times.
Hello.
Yes, Ashmita.
Oh, ma'am,
Please let her.
just again click on share button and select the current slide. So your
No, it
PPT.
doesn't show me the current slide. It shows current content only as background over the shoulder, side by side. Or it shows whiteboard. I don't understand. It doesn't show my presentation at all.
Uh, have you you're having your PPT in front of you?
Yeah, I am.
Ma'am, just try once. Yeah, select your presentation.
Can you see it now?
Yes, yes, I can see, but select your presentation and
I have
right hand
selected
side
it.
bottom open.
I've selected it. Is it not playing now?
No, click on open button, right hand side bottom.
Where is the open button? I don't see anything.
You just click this presentation. Yes, now we are able to see.
Okay, thank you.
Now we are able to see. Yeah.
Sorry, thank you. So We reported on the prevalence of FTD long back, more than 20 years back from Cambridge, and where we found that the early onset FTD and AD, the prevalence is similar, about 15 per 100,000 in the 45 to 64 years group. So it's an important cause of early onset dementia. That means between the ages of 45 to 64 years, and it's under-recognized in older age. So 30% can present with when they are more than 65 years. This is an important point to remember, especially the motor variant of FTD. So recently there has been a meta-analysis of 9 European countries epidemiology. It's a retrospective cohort, and the incidence has been given as 2.36 per 100,000 person years. And BV-FTD is the commonest presentation in 40%, primary progressive aphasia in 28%, and Parkinsonian in 26%, and ALS was much smaller, 5.6%. 36% had family history. And the prevalence is 9.17 per 100,000. So the important points I want to make here are that diagnosis of FTD should be considered at any age, and it's probably more commoner than previously recognized. So there can be a delay in the diagnosis of frontotemporal dementia because of the heterogeneous presentations, and some of them present with personality changes or psychiatric manifestations, and it can be mistaken for a primary psychiatric disease. So there can be a significant delay in the diagnosis, and which we also saw in our clinic, cognitive disorders clinic. The apparent median time to diagnose was significantly more for FTD, 30 months as compared to other dementias. So please note, actually, this delay is not significant in terms of what is reported in the literature, but I think that our patients do sometimes round off the figures, and the apparent delay may be even, the real delay may be even longer than 30 months because patients were significantly impaired at diagnosis, suggesting delay was longer. Like these studies illustrate from Calcutta, Dr. Ghosh, and also there was a cross-cultural study between USA, Greece, and Turkey, which showed that even though the duration of illness was less in Greece and Turkey, patients were more impaired compared to patients with diagnosed in US. The disease was more florid with higher NPI CDR scores and lower MMSE scores, suggesting that the actual real duration may be longer and the families may have not noticed the onset of symptoms. So coming to the different types of FTD, so I'll try and illustrate each type by showing a patient. So the first would be behavioral variant FTD, which presents mainly with behavioral and personality change. You also have a right temporal variant, which also presents with behavioral changes. Then there can be an aphasic variant, which could be either semantic or non-fluent, where they have problems in finding words or understanding speech, or there can be hesitancy and loss of fluency. There can be also a motor syndrome, as I already mentioned. So the disease begins within the brain in few epicenters. So there is prominent atrophy at clinical presentations, and these have connections to brain areas that degenerate in later stages of disease. For instance, if you talk about the BV-FTD, it begins mainly in the anterior cingulate and the frontoinsular cortices. And in the semantic PPA, it's the inferior mesial temporal poles. So this is a patient who came with 3 years personality change. Post-COVID became very dull. He's only 42 years old, highly educated, and speaks multiple languages. So he changed several jobs. He stopped working and became extremely restless. He would go for a walk for 5 minutes, come back home. He also became disinhibited, inappropriate comments to strangers, increased eating of sweets. He had cognitive complaints. There was no family history. So he was treated by a psychiatrist, which is the usual story in at least 50% of patients diagnosed as depression, and obviously he didn't improve. On examination, he had no insight. He made several inappropriate comments like, "Are you married? Is your husband dead?" Extremely restless. His ACE, please note that the Addenbrooke's cognitive scale examination was very good. but he had reduced phonemic fluency and he was impaired on trails, and there were no extrapyramidal signs. And here you can see the MRI, it's showing frontotemporal atrophy, asymmetrical left more than right. So this is characteristic of behavioral variant FTD. There can be changes in personality and behavior. The person no longer seems the same kind of person, seems to be replaced by somebody who is disinhibited or very apathetic, has no initiative, has lost empathy, or they can have changes in eating behavior, food fads, stuffing their food, eating a lot of junk food or sweets. And they can also have executive dysfunction with relative sparing of memory and visuospatial function according to the criteria of Raskowski. So there is a characteristic bilateral orbitofrontal as well as medial frontal atrophy, but the absence of atrophy does not rule out BVFTD, and frontal and temporal atrophy can occasionally be seen in the behavioral AD variant. So one should be careful that just because there is atrophy, it need not be BVFTD, and if it is absent, it doesn't mean that it is not BVFTD. So the hallmark of abnormality is an impaired social cognition in BVFTD, where they have lack of empathy. They are no longer sensitive to the people's feelings around them. They can have impaired theory of mind, ability to understand others' mental states, poor social perception, that they don't read the room very well. They're unable to read facial expressions or social cues, and they can become tactless. They can have loss of manners. And there are different tests which can be used to diagnose the social cognition, including FOPA test, emotion recognition, interpersonal reactivity. But all of these take considerable time in a busy clinic. So recently, there's also been a neuroanatomical and cognitive model for social cognition, which suggests that there can be impaired semantic knowledge, which is here in the resides in the anterior temporal lobe, especially the pole, which is in purple. And there can be disconnection, or the social control centers are, there is atrophy in these regions, the orbitofrontal in yellow here, or the ventrolateral prefrontal in blue. So there can be either a disconnection between these two areas, or there can be atrophy in these areas, which can cause impaired social cognition. This is a recent study from the Frontiers group in Australia, and they looked at how patients with BVFTD fulfill the Raskowski criteria, which we have always had problems in our cognitive disorders clinic. So they found that apathy and loss of empathy were the most common features in their 110 patients, but isolated executive dysfunction, which is one of the criteria with impaired episodic memory and visuospatial function, was uncommon, and it was seen only in 14.5%. More importantly, 10% had isolated episodic memory deficits, but still they turned out to be BVFTD. These are either have a proven mutation, or in retrospect, they have a postmortem diagnosis of BVFTD. So these are definite BVFTD patients. So you can see that we can have problems with criteria, especially in the cognitive domain. In our patients, it's very difficult to get the loss of empathy unless you ask leading questions. Many families don't come out with those symptoms. So this slide briefly shows the kind of patients which we have been seeing in our clinic at Bangalore and Mysore. And we have had 328 patients over the last 15 years, or FTD. And the BVFTD was the commonest subtype which we saw, followed by semantic dementia. But we had very few PNFA. Most of them had motor disorders associated, and also very small number of FTD MND. So the first symptom was behavioral in 45%, followed by language in 28%. And there was men were more predominant as compared to women. The age of onset was, this should be diagnosis, I'm sorry, was slightly higher. They're not so young as what is reported in the literature. and their scores on ACE and MMSE are quite low, as you can see, even though the CDR was mostly 1. So in our cohort, we found that apathy and repetitive behaviors were the most common neuropsychiatric features, followed by food fads and gluttony. Disinhibition was not that common, but repetitive behaviors were very, very common. Simple pacing, multiple toilet visits, sending the same WhatsApp video or messages several times, and psychosis was uncommon. So racial disparities in neuropsychiatric features is known. So this is a paper which came in 2023, but they had a very few diverse population, only 2.5% Black or Asian. But they noted that Black individuals had a higher frequency of delusions, agitation, and depression, while Asian individuals had higher frequency of apathy, nighttime behaviors, and appetite eating change. So these are some things which probably need more investigation. Here, this is a patient who wrote the Gettysburg Address. He was obsessed with it. 7 years ago, our fathers brought forth. So this is the same sentence he wrote even after 3 months or 6 months, whenever he would come to the clinic. And this is a patient who was coloring books and constantly finished 100 books in 1 year. He was ironing clothes excessively, washing hands. So like I mentioned, there can be some cross-cultural differences in neuropsychiatric features, which have been reported from Japan, like eating disorders, but weight gain was less common. Hallucinations were more common in people with African descent. And Ghosh and colleagues have reported that there's a high frequency of utilization behavior and imitation behavior in Calcutta, but which we have not seen. But this is a very, very old video from NIMHANS, where I've seen a patient with FTD. And here you can see the utilization behavior. The person is asked not to touch any objects in front of him. Explicitly, the instruction is given, but they cannot resist. So he's taken the ring, he's wearing it, he's taken the money. So this is an example of utilization behavior. So we are planning to evaluate this cross-cultural diversity in FTD across 16 countries, where we are trying to examine the frequency, type, and nature of behavioral and psychiatric features of FTD across different countries. Because like you saw, sometimes the patients may not fulfill the criteria when they come at presentation, because for instance, our patients may not have lack of empathy or even disinhibition, but they have only some features which can make it only possible. So it does affect the diagnostic accuracy. My Scandinavian colleagues say that it's very difficult to diagnose apathy in them because the relatives do not report apathy, but disinhibition is very easily picked up by the relatives. So now we move on to a different variant of FTD. Here, this is a patient who came at 58 years. He started having problems, difficulty in recognizing faces, recalling name, became very rigid, inappropriate humor, also had difficulty with names of objects, decreased conversation, repetitive themes. So his ACE is excellent, as you can see, 93 by 100, but naming was impaired subsequently, not initially. Famous faces was impaired even at the first presentation. And this is his MRI showing predominantly right temporal atrophy. So there is a right temporal variant FTD. We have come up with some criteria, and we are trying to refine this criteria by applying it to a prospective cohort of patients. This is again Neuropsychiatric International Consortium of FTD. We have joined and trying to refine these criteria so the patients can present with either behavioral features, semantic features, or prosopagnosia. But many of them have hypochondriasis, hyperreligious, visual hallucinations. And on pathology, they can show tau or FTLD TDP type A and B pathology. Unlike the semantic variant, which has mainly left temporal atrophy, which can be associated with TDP type C pathology. So now we move on to the language impairment, the primary progressive aphasia. So this I got from the net.
I used to do presentations and talk to the staff at times. That's all gone now.
So can she see the difficulty in fluency and hesitations in speech? And this is a patient we asked her to repeat.
Gandhi. Rhinoceros. Georgia.
So you can see it is completely impaired. So she's not able to, there is a lot of distortions in the repetition. So this is a patient with non-fluent aphasia. Unlike this patient who has difficulty with words and understanding concepts of 6 years, he'd forgotten the names of vegetables and fruits. He was asked to buy carrots by his wife. He was going grocery shopping. He said, "What is carrot?" And he was asked to switch on a generator. He switched on the heater. So became more miserly, hyper-religious, watching YouTube videos, decreased empathy. So his naming is very impaired, as you can see here. And he had characteristic left temporal atrophy. This is a patient with semantic variant aphasia. So the primary progressive aphasia can be divided into non-fluent or the agrammatic variant and semantic variant or semantic dementia. And non-fluent, we can have agrammatism, effortful, halting speech, speech apraxia, and they can have impaired comprehension of basically syntactic comprehension, where the grammar they cannot understand. And semantic aphasia, they can have impaired word picture matching, impaired naming. They can also have surface dyslexia. And they are already, I showed you the scans, they can be associated with specific atrophy patterns on the scan.
ನೀವೇನೆಲ್ಲ ಭಾಷೆ ಮಾತಾಡ್ತಾ ಇದ್ರಿ ಮುಂಚೆ?
ಇಂಗ್ಲಿಷು ಹಿಂದಿ ಎಲ್ಲಾನು ಮಾತಾಡ್ತಿದ್ದೆ. ಈಗ ಬರೀ ಕನ್ನಡ.
ಇವಾಗ ಮರ್ತೋಗಿದ್ಯಾ ಮಾತಾಡೋದು? ನೀವೇನೆಲ್ಲ ಭಾಷೆ
So this is a patient with semantic dementia. We found that people who speak more than 2 or 3 languages are no longer able to speak the other languages. And here, this is an example of word picture matching. The examiner calls out the word and he's asked to show. So he's able to not show this. So he's showing you the pig.
ಮತ್ತಿವೆಲ್ಲ ಏನು? ಎಲ್ಲ ನಾಯಿಗಳು.
So this is a very common response. So they refer to all animals as dogs, and when the disease progresses, they may just call everything animal. So this is an example of semantic dementia again. So we also looked at what happens to languages in primary progressive aphasia and bilinguals, because as all of you know, bilingualism is very common in India. What are the factors which influence the decline, the proficiency, age of acquisition, usage? Because there is very little literature in the world on languages other than English. The important thing is it also affects the diagnosis. For instance, surface dyslexia, that is irregular words are difficult to read by patients with semantic dementia, like mint, tint, but it's not pint, it is pint, P-I-N-T. So they have problems, but many of our languages have transparent orthography in India. So we don't have irregular words. So there may be a problem in diagnosing surface dyslexia. So we reported this earlier where we saw 16 patients with bilingual semantic primary progressive aphasia, and they could only speak the first language. They had lost the L2 and L3, and this was seen across different kinds of patients, English or other languages, even literate, illiterate, and so on. And we are investigating this in more detail. Jwala Narayanan is doing a PhD under this, and we are also comparing them with the age-matched controls, as well as Alzheimer's disease patients who also have bilingual, who also have semantic deficits. Here you can see the word picture matching, which I just showed you, across languages was unimpaired in patients with Alzheimer's disease. This is an easy task, but there is a difference between the two languages for patients with semantic dementia, suggesting that the later languages or less proficient languages are very vulnerable to neurodegeneration. So we then come to motor syndromes, where we have progressive supranuclear palsy, corticobasal syndrome, and motor neuron disease. All of you are very familiar with all these features. And if they have some features of BVFTD, and there is criteria laid out how we can diagnose the FTD overlap syndrome, one can consider the diagnosis. So 5 to 10% of FTD have MND, but 40 to 50% of ALS patients can have FTD symptoms. So they can have, so one should look for very carefully amyotrophy as well as look at the tongue while seeing a patient with a frontotemporal syndrome in the clinic, as well as emotional lability. So I will move on. So the other important point I would like to make is that there is overlap of clinical subtypes. Though the classification has been laid out as distinct different types, there can be overlap between the types. So they are not distinct. That is what you don't see in the clinic. For instance, a patient with BVFTD can have a non-fluent aphasia. They can also have Parkinsonism. And similarly, the semantic variant PPA can have behavioral features, and the non-fluent PPA can also have different kinds of motor disorders. So it's very important to diagnose, differential diagnosis is very important in FTD. So I have listed out most of the different diagnoses which we have seen over the years, including B12 deficiency, neurosyphilis, HIV, vascular dementia. So I've had patients referred to me as BVFTD, even though the scan is showing clearly infarcts in the basal ganglia or in the frontal. So one should be very careful in making a degenerative diagnosis when you already have something which can explain the syndrome. Spontaneous intracranial hypotension, a rare cause for causing FTD-like syndrome, but one should remember that primary psychiatric disorder is a very important consideration. BV-FTD phenocopy and neurodegenerative disease, especially Alzheimer's disease patient, the dysexecutive or the behavioral variant. So there can be different red flags which we can look at. And autoimmune disease is very important, but sometimes patients can have some kind of overlap with neurodegenerative disease. Several researchers have published on this, including Suman, who has presented patients many times. So, but the best way to resolve this is to keep the patient under follow-up and evaluate the patient with both serum and CSF autoimmune antibodies. But we must remember that every frontal behavioral syndrome is not FTD, and every dysexecutive syndrome is not FTD. So one should be very clear before making a diagnosis of FTD. There can be a prior diagnosis of psychiatric disorder in more than 50% of BV-FTD patients. What I find is that sometimes the neurologist may overdiagnose BV-FTD, but the psychiatrist may underdiagnose BV-FTD, and patients have been under the label of depression or a bipolar disorder for many years before anybody had a good look at the scan, or the scan may not have been ordered, or they also have family history. So it's very important to make this distinction. So this can be a challenge in the clinic. It is not so easy to differentiate the two because patients can have a very long history. So it's very important. So again, we had some recommendations from the NIC FTD consortium, which we published in Brain. But the most important thing is to do serum or CSF neurofilament light chain. So these levels can be very high in patients with FTD, but they are near normal in patients with primary psychiatric disorder. Even though this is a non-specific test and is not diagnostic of FTD, but it can be useful to differentiate FTD from primary psychiatric disease. One should also realize that C9orf72, which I will talk about a little later, a mutation, they can have psychosis. So 30% can have psychosis. So there can be some overlap between these disorders. As I mentioned, be aware of overdiagnosis. This is a study where they found that 60% of patients in a specialist clinic who were referred as BVFTD did not have BVFTD. The false positives were more likely in depression, non-Caucasian patients, less euphoria, apathy, milder disease, better cognition. So as I already mentioned, that one should always be careful before making a diagnosis. So there is something called phenocopy syndrome where the person is presenting similar to a BBFTD in terms of the personality changes, but they do not progress. They have stable cognition and social cognition. The MRI is normal. And usually these patients are male. They're brought by their wives 50 to 60 years. And some of them can have C9 of 72. So they can be a mutation carrier. So it would be worthwhile to explore that. But recently, researchers from Amsterdam presented a large series of phenocopy syndrome, and they found that many of them seem to have some kind of personality disorder, and they've been married several times, and the wives bring them with these kind of symptoms where they are very apathetic or they have some impaired social cognition. They don't read the room very well. So it could be, they also suspect whether they have had childhood abuse. There could be a personality disorder, late onset schizophrenia. So we still do not have all the answers, but again, these patients should also be followed up. But complete normality on the MRI, no progression may suggest that it could be phenocopy syndrome. So cognitive reserve is an ability of the brain to withstand pathology. So education, occupation, even bilingualism can provide cognitive reserve. So because this is an important area and very interesting to people in India, so we investigated this in our clinic and we found that only for FTD, there was a delay of 8 years in age of onset in bilinguals as compared to monolinguals, but it was not seen in other subtypes. But the caveat is that the monolinguals were less in number, they were less educated. And this is a retrospective study, and the regression analysis we did, it was controlled for education, but still it seems to be quite striking. And one of the reasons is that when we switch languages, we have to inhibit one language. And so there's a cognitive control as well as switching, inhibition, which are executive functions. So we think that that could explain why it was seen only in FTD, but not in other dementia subtypes. So biomarkers for FTD, right now, there is no biomarker which we can diagnose. There's a lot of research going on. Like I mentioned, neurofilament chains are non-specific. They can be high, but it doesn't distinguish that from other subtypes. So there's also some things like plasma glial fibrillary acidic protein versus the NFL ratio, which can be lower in TDP, but not in tau. And people have tried to measure TDP, and they've measured p-tau 181 over tau ratio, CSF tau isoforms. But these are all undergoing research. We may have better biomarkers in the future, and it may be very, very close. So this is a recent study in Nature Medicine 2024, and this seems to be very promising. They've looked at plasma extracellular vesicle tau and TDP43, and they feel that these are really discriminated between FTD and ALS, and FTD with different pathology, the tau and the TDP43. So just like, and we also have biomarkers for AD now available in India. We have the p-tau 217 amyloid ratio, which is done from several centers in India, and that can at least rule out Alzheimer's disease if you have doubts as to the diagnosis. So there are some advances in tau PET, but nothing which can be used in the clinic context. But there's been a recent paper by Kuboto et al., which looked at tau PET imaging with Thorzo, low tau in 26 patients with frontotemporal dementia, and they seem to distinguish between the 3-repeat tau, 4-repeat tau, and the Alzheimer's disease presentation, as seen here. very nicely, but we don't know whether we need to replicate these studies and find out whether they really work in a large cohort of patients. So this is very important, the genetics of FTD. So positive family history, unknown genetics in 25%, we may not find anything. And negative family history, this is sporadic variant in 45%, but the rest can have some mutation. These are the three main mutations, the tau mutation, progranulin, and the C9orf72 mutation. And there are also other mutations which have been reported, but the frequency is quite low for these mutations, and especially the TBK1, the TARD, DBP proteins, they can also have mutations. So they have different association with different pathology. As I mentioned, the MAPT mutation is associated with chromosome 17, and more than 80 mutations have been described. So patients are usually younger, and they can present with motor disorders, but they can also have semantic impairment. Here, the atrophy is more symmetric and more temporal, and the hyperphosphorylated tau aggregates in the neuron and glial cells. Then we have the progranulin mutation again on chromosome 17, and these are again characterized by TDP43 accumulation. The mean age is slightly older. They can have more apathy, and usually the presentation is either aphasic variant or a BVFTD. And on the scan, they have asymmetric atrophy, which is quite striking. The C9orf72 is a hexanucleotide expansion in the non-coding chromosome 9p21. And they are associated with either with BVFTD, MND, or Parkinsonism, but psychosis can be characteristic. And they are younger for 58.2 years, again seen with TDP43, and they have symmetrical atrophy. So these are the salient features which I've already gone through most of these. What are the common presentations? What is the age at onset? Whether they have penetrance, common clinical phenotypes, and also the MRI. And you can access this in the reviews in neurology of 2024. Again, I ask you to read this Grossman et al. 2023 in Nature primer on FTD. It's a fantastic article, very beautifully written with lots of illustrations. So please go through it if you're interested in FTD. So there's been a paper which tried to show the geographic distribution of genetic subtypes of FTLD. And when this paper was published, India, you can see here, there's only one which has been, one mutation was reported, the progranulin mutation. So as you know, subsequently, there's been work done from NIMHANS, and they reported both the MAPT and novel TBK1 mutations. But this suggests that a lot of work needs to be done in India, because most of the treatments which are available, I'll go through, are targeted at specific pathology in most of the genetic forms. And we do not have any kind of cohort of these genetic FTD in our country. So along with Suman and other investigators across 6 centers in 3 states, we tried to form an FTD genetic consortium. This study is ongoing, and we are trying to identify mutations in known genes in FTD, do a genotype-phenotype correlation, and also explore plasma-based protein biomarkers in FTD. So the main goal is to see how we can enroll patients in India in clinical trials, because unless we have a substantial number of patients with some genetic form of mutation, we may not receive the clinical trial. So here I've listed several ongoing clinical trials for FTD. So many of them target the genetic mutations, especially progranulin. There has been a lot of interest in it. Either they are delivering the progranulin gene directly to the affected brain areas, or they're using viral vectors. And there are also ongoing studies in tauopathies. In fact, there are lots of trials which are going on. It's mind-boggling. So we await the results, because it's very difficult to even go through each one and talk about them. but some have been negative, even though, like for instance, the latozinemab, which blocks the sortilin, so the progranulin levels increased both in the brain as well as in the CSF, but it did not lead to any cognitive or behavior improvement, did not slow progression. So they're also studying something which can be given by mouth, not by those complicated procedures. And phase 3 will probably start soon. So what are the prognostic markers? This is an old study which I found in 2021. I've not seen any substantial recent studies which talk about this, but poorer survival is with especially motor neuron disease if is attached, older age at onset, autonomic dysfunction, psychosis. So there is a lot of higher NFL levels. And so these are some of the, and there's also some improved survival in higher occupational attainment, C9 or tau positive, 3R tau, change in eating behavior. But the life expectancy is usually 3 to 14 years from the symptom onset. So this slide illustrates the complexity of FTD with the underlying genotypes and the molecular biology. As you can see, there is a lot of overlap between the distinct clinical subtypes. There is also overlap in the pathology and in the genotype, which can be seen. So we try to highlight these gaps in the low and middle income countries, along with our colleagues from iStart of the Alzheimer's Association across different countries. But I think it's no longer important to just to highlight the gaps. We should work towards overcoming these challenges and barriers in research so that our patients, our families can also get to clinical trials and be part of this global studies, research studies. So I would like to conclude by saying that for the diagnosis of FTD, consider the complete clinical picture, the cluster of symptoms rather than an individual symptom. Make sure that you rule out secondary causes, and to differentiate from AD, do the blood biomarkers. And please consider referring to specialists for genetic workup, because we can't have individual people working on these. We need to work as a team to provide some kind of genetic background on these patients and the families. As I mentioned, participating in global trials is very important for the families, because I've had patients who are trying to reach out and they're even willing to travel to Europe or US to take part in the clinical trials. So the caregiver burden is huge for these patients. I've not gone into treatment because there's no specific treatment. So on the families, the burden is huge. So it's very important that we do a concerted effort in India to address this. And it's also important to refer the caregivers to the local and the national organizations which provide support to families and the resources, which is of paramount, because it's not just about diagnosing. So we are trying to do a bit for creating awareness. So we did the first public awareness campaign on FTD online. And recently, Sweta Mohan, who's working with us, got the Kisik Family Foundation grant. So she's going to start resources for families with FTD and a website and a toolkit to support them. And this will be multi-discipline, multi-center study in Delhi with at Sabdajang, Atri Chatterjee, and also Sri Chitra. And Bangalore, we are participating in this study. So besides diagnosing and trying to support the families, we also run a CogWorks, a novel self-sustaining enrichment program, where we offer different kinds of activities like yoga, movement therapy, and we manage mainly with the volunteers because we don't have funding right now. And we also use arts, and this was the brainchild of Jwala Narayanan, who's a neuropsychologist in the Cognitive Neurology Clinic. So I can just show you the brief video if I have 2 minutes. So this, I would like to acknowledge our patients and their families, my teachers, and all my collaborators, the Cognitive Neurology Clinic team, for doing all this work. Most of this work is unfunded, and it's just for maybe 30 seconds. I'll show this.
We do different activities here. So we do a lot of painting, craft, and here our motto is to actually use different modes even when we are painting. So we paint on different material, we use different kind of paints. We do a lot of different kinds of art and craft. So in craft, we try to use waste plastic, we turn it into wind chimes, we turn it into wall hangers. We do repair, and we do a lot of yoga, movement, and games. So most of our yoga is chair-based. Even our movement does not involve a lot of meticulous physical exercise, but it's mostly for them to stretch and enjoy themselves. So generally, we show them the Cogworks room and the yoga and movement room so that they can see the options available to them. So we have various stations such as cooking, stitching, painting on different mediums, whether it's tiles, bottles, or even the garden wall. So we try and cater something that they like. And though we want them to try new activities, we always make sure that they enjoy it, or we change it according to the way that they enjoy it. For example, we have two Navy men, and one of whom is actually an aircraft engineer. So both of them really love building model planes and model ships.
So thank you very much, and I'll be happy to take any questions. How do I stop sharing?
You have stopped sharing. It's
Oh, okay.
the slide is not there.
Okay, great.
Suman?
Thank you.
You're there?
So thank you for elaborate elaboration of the clinical points, the clinical manifestation, the genetics, and the recent advances in frontotemporal dementia. And we have some questions which I think are related to. Somebody has asked, please explain the surface dyslexia and deep dyslexia with examples. Can you see the question? Yeah.
Yeah, surface dyslexia is the inability to read irregular words, as I mentioned. So if you have words like mint, tint, and then you have pint, P-I-N-T, so which is pronounced pint, because in English is a language where the pronunciation is always very difficult for many of us. So that is the surface dyslexia. Which can be seen in where there are irregular words. That means the pronunciation is dependent on us recognizing what is the meaning of that word and then pronouncing it appropriately. So many of the Indian languages are transparent or have transparent orthography. So they don't have any, what should I say, irregular words. So that is what we see
So
in
the next question,
dementia.
yeah. Okay. The next question is by Dr. Joy Desai. He's saying, wonderful lecture. Is the pathogenesis dominantly gene-driven? Failure of the protein biology and aggregation, or any lifestyle biological contributes?
Okay. So, I mean, there is some breakup when you're talking, Suman. So, but I could understand. So the thing is that, of course, it is gene driven, and gene driven and the abnormal protein as far as the genetic forms are concerned. But as I mentioned, at least 60 to 70% of the FTD is sporadic. So we do not know exactly what happens in those forms. And there are some researchers now who have made that their focus of interest, because we need to understand why there is sporadic FTD. Is it because we are not able to find the mutation in these patients, or is it something else, or they have a multifactorial pathogenesis as in Alzheimer's disease or something. So these are under research, but definitely there is a protein, the gene product failure in those genetic forms, which is linked to pathogenesis.
Okay, and we have a question from Dr. Apurva Puranik. Uh, that is, non-fluent PPA has shown that fluency and grammar are disable, and that so-called broadcast area merely work as a coordinator. He wants to ask.
Fluency and grammar. Okay, so there are definitely in non-fluent aphasia, there are two variants called apraxic aphasia and agrammatic aphasia. So the previous one is associated more with problems in fluency where there is distortions of speech, and in the agrammatic there is more of syntactic comprehension deficit. So people have looked at these two disorders, and the speech apraxic disorders are more associated with motor disorders also. So that is one thing which I know about the two variants of. So I think also our localization and understanding of aphasia has progressed beyond what we have learned previously from stroke aphasia, that only there is, so the epicenters are probably important, but there are also many areas which are coordinating and participating when we are either talking from phonology, semantics to phonology, or phonology to semantics, and vice versa. Though there are key areas, there are many areas which are coordinating and producing in production of speech.
We have one question from Dr. Subhash Paul. He's asking, do anticholinesterase worsens the frontotemporal dementia, and do SSRIs make any difference in their behavior?
So cholinesterase inhibitors can cause worsening of behavior, which has been documented in literature, and we have also found, especially if they're already agitated and irritable. So the irritability and agitation can increase. Even in patients with Alzheimer's disease, when cholinesterase inhibitors, they're in the moderate stage to severe stages where the person is quite disruptive, we actually reduce the dose and see if the behavior improves. So ideally, we would not be giving those medications in FTD unless you're suspecting some logopenic aphasia, which can be something which can be related to AD. That is number one. SSRIs we use very widely, and I have discussed this with my colleagues across different countries, and they all use SSRIs in patients with FTD. So we use mainly escitalopram because it's the easiest one to titrate if there is no hyponatremia, because that can reduce that agitation. It can reduce that repetitive behaviors people can have, going to the bathroom several times, talking about some theme. So that is what we use first before using atypical antipsychotics. Many of the clinicians are surprised and they ask the family, why has she started the SSRI? There is no depression. So the other thing is that even patients with FTD can have depression. They can have apathy, but they can also have depression. Both can coexist together. So even to improve apathy, SSRIs can be useful.
And there is a question from Ratnesh Sharma. In your opinion, is there any role of pimavanserin, the newer drug, for psychotic symptoms and agitation in FTD?
So the answer is I do not know. I know only it's been tried in patients with Parkinson's disease. So I'm not aware that anybody has used it or even read any reports, even case reports. So if any of you have any more knowledge, please let me know. But I'm not aware.
It is being used for psychosis in Parkinson's disease as far as we are doing it.
Yeah.
It is used in psychosis with Parkinson's disease, but not with FTD.
Yeah.
And there's one more question. In FTD MND, would you like to give edaveron or riluzole?
So I don't know, even in MND, I don't find them very useful. So I'm not sure whether we should use those drugs in FTD MND. The progression is definitely faster. FTD MND combination, the progression is much faster.
And here is another question. Sonal has asked, what is your experience with FTD MND and their life expectancy, progression, and if any, tips for clinicians for early neuropalliative work?
Neuro? Palliative.
palliative work. Yeah. FTD, MND.
Yeah, so we have not seen such a huge number of patients, but obviously, if there is, so we definitely refer to the speech pathologist for one to anticipate any swallowing problems. Even with any FTD with motor disorders, we would like to refer to a speech pathologist and work with them together for evaluation of swallowing and speech. And we also involve neuromuscular disorder specialist if we see patients with MND. And palliative care, we explain to the family because sometimes they are still active and they may just have atrophy. So it depends on what stage the patient comes to us. Definitely, we involve the palliative care if there is anything specific. So I'm not sure whether I've answered that appropriately. The panel can add to my insufficient answers.
And I have a question, ma'am. How often you do neurofilament light chain for differentiating the psychosis versus behavior variant of FTD? Because this is very common in clinical practice. That the patient is psychosis
So
or psychotic disorder versus FTD. So how often you do this neurofilament chain?
So I have not done so far. That's a frank answer. So we have just started using AD biomarkers in the last 4 months. So we have not used any NFL. So I've only heard that there can be a problem with the values, the way the NFL test is done in India. So I'm not very familiar with it, but with the technique. So I don't use it as this thing. I also don't do much of FDG PET in my diagnosis. We used to use it extensively when we started initial evaluation of patients. I find that the way the FDG PET is done, there are so many limitations to the process as well as interpretation. So many times it's not useful. So if we do not have the answers, we keep the patient under follow-up. So many times we don't tell that it is BVFTD unless we are really sure. To illustrate, like I saw this patient, right temporal variant who came to us. It's like he didn't have right temporal lobe when he came to us. And he came alone, asking some questions about something, so which was very non-specific. But we didn't call him first right temporal variant because obviously we need to be clear and we are labeling somebody as a neurodegenerative disease, so we should make sure. But please let me know where people are doing NFL. So if you have any leads, I know that Amrita Institute is doing in India,
Yeah.
NFL.
I think one of the biomarker companies are bringing NFL shortly, within a couple of months, I think, as I'm told, both NFL and GFAB. We'll wait and see. We'll wait and see. That's what I've heard.
Yeah,
So
I've also heard that, so I await that. So because it's exciting actually to use the biomarkers to support and confirm your diagnosis, like the p-tau 217, which initially we were very worried about, many things like whether it works in patients with CRF, whether it will work in patients with vascular factors and all. There's so many studies now which have come out, and in fact, they have said that p-tau 217 alone is better than even adding other biomarkers to the panel. So there are a lot of research which has come out independently in Nature and Alzheimer's and dementia, which suggests that, and JAMA, which suggests that it's an excellent biomarker. So I think that we will have something similar for FTD very soon.
So we don't have more questions, ma'am. So I think the session was wonderful, and we get to know a lot of new things about FTD. And I hope the people who have attended must have enriched in their knowledge about FTD. And I would like Dr. Amitabh Ghosh to end this.
Thank you very much, Suman, and thank you for another very wonderful lecture, Dr. Vali. Thoroughly enjoyed it, and we've learned a lot. I'm sure all of us have. Thank you very much for coming. So we'll if Ashmita agrees, we will close the session here, and
We
we
would
look
like to
forward
extend
to.
our, yeah. We would like to extend our thanks to digital team, IAN, for giving us this opportunity, this platform to do the webinars on cognitive neurology. Thank you so much. Thank you so
Thank
much,
you.
ma'am,
Thank
once
you very
again.
much. Thank you.
Thank you.
And also thanks all the participants. Thank you so much.
Yes. Thank you.
Thank you. Bye-bye.
Bye.